Good afternoon, everyone. We'll be getting started momentarily. We're just allowing the audience to merge. Okay, we'll get started. So good afternoon and welcome to today's learning session, Rebuilding Trust, Partnering for Improved Outcomes. Today's event is brought to you by the Health Quality Innovation Network, or HQIN. We are your CMS-appointed Quality Innovation Network Quality Improvement Organization, and our goal is to assist nursing homes in Kansas, Missouri, South Carolina, and Virginia with quality initiatives at no cost to your facility. Before we get started, let me review a few housekeeping items. Everyone is currently muted and in listen-only mode. If you have questions or would like to share, please use the Q&A icon at the bottom of your screen. Or you may click Raise Your Hand if you would like to be unmuted to ask your question. The presentation from today's session will be provided via a link in chat. That's the most popular question we get, so if you're looking for the presentation, please go to the chat bubble, click on it, and you'll see the link. At the end of today's session, there will be a short evaluation. We would appreciate you taking a few moments to complete so we can better serve you in the future. If you encounter audio challenges, click Audio Settings in the bottom left-hand corner of your screen to adjust your settings. Or you can also listen by telephone. The phone number was provided in your confirmation email. I'm Allison Spangler, Quality Improvement Advisor with the Health Quality Innovation Network, and I will be your host. I'm also joined by Mary Lachlan, Quality Improvement Advisor and Infection Preventionist, and Laura Finch, Geriatric Nurse Practitioner, who will assist with Q&A, chat, and facilitating today's conversation. We are extremely excited and fortunate to have three wonderful guest speakers today. Brenda Groves is a licensed nurse with a wealth of knowledge and experience in dementia, geriatrics, healthcare quality, risk management, and patient and family engagement. She currently serves as a nursing home quality improvement advisor in Kansas. Brenda provides assistance to nursing home teams as they work to improve the quality of care and quality of life for those they serve. Next is Mitzi McFatrich, serves as Executive Director of Kansas Advocates for Better Care, a statewide consumer advocacy organization founded in 1975. KABC launched the nursing home reform movement in Kansas and was one of a handful of consumer advocacy organizations to secure passage of the landmark 1987 nursing home reform law and improving long-term care for millions of older adults in the U.S. KABC's mission is to improve the quality of long-term care wherever an older adult lives, at home or in an adult care facility. Since joining KABC as Executive Director in 2007, Mitzi strives to engage and amplify the voices of older adult consumers, caregivers, and elder advocates in policy decision-making. Under her leadership, KABC launched a 6-year, 30-community training tour to introduce a multidisciplinary team approach to prevent and intervene in elder abuse, neglect, and exploitation, bringing together older adults, caregivers, law enforcement, aging and social services, and banks. She often presents on elder care and abuse issues nationally and in Kansas, and is an expert consultant with the Centers for Medicare and Medicaid Services. Mitzi provided in-home care to both of her parents along with her sister and family, learning firsthand the joys, rewards, challenges, and heartbreaks that come with being a caregiver. Michael Rajewski has over 40 years of experience in the healthcare industry. Michael has a Master of Science in Management from Friends University and a Bachelor of Science in Psychology from Fort Hays State University. Michael also has his Healthcare Services Executive Certification by the National Association of Long-Term Care Administrators Board. Michael is a licensed State of Kansas nursing home administrator and is also a certified CPR instructor with the American Heart Association. Michael is currently working for the Congregation of the Sisters of St. Joseph as the Center Administrator for Mount St. Mary, Inc. in Wichita, Kansas. So let's briefly review the goals of our webinar series. Our ultimate goal is to assist in increasing resident COVID-19 booster uptake. So how do we do this? We provide the most current information related to COVID-19 vaccinations and a forum to collaborate with your peers. This forum is a safe space for everyone. We strongly encourage all attendees to interact during these sessions. So please ask your questions. You have a wealth of knowledge and expertise at your disposal. We would also love for you to share what is working and even what hasn't worked in your efforts to increase vaccination rates. So with that, I'm going to turn the presentation over to Brenda Groves. Brenda?
Thank you, Allison, and thank you everybody who's with us today for joining us. Today we're going to really start looking at how the COVID-19 safety protocols and the regulations really influenced and changed our relationships with our families. We're going to review strategies to enhance your patient and family engagement program. And then Mike is going to be sharing with us some strategy and action and how his team engaged his residents and his community to have a success within their vaccine clinics. So you can move to the next slide, please. In March of 2020, when we were all faced with the overwhelming COVID pandemic, all healthcare settings across the United States as around the world were required to restrict visitors and restrict family members from coming into our buildings with the ultimate goal to stop the spread of the virus and ensure the safety of our staff, our residents, our families, and our community. Generally, that meant families were now restricted. They were not allowed to be present with their loved ones. Their ability to participate in care planning, and decision-making was severely limited. While this initial response is understandable, given the significant clinical complexity of COVID-19, as well as all of the uncertainty that truly existed at the beginning of the pandemic, it is absolutely crucial that we revisit it now that we know so much more. As the slide that you're seeing notes, restricting families was one of the darkest experiences for our clinicians and our teams. We understand that. There's been a lot of focus and a lot of research lately trying to identify and discuss the negative impact COVID has taken on our residents and on ourselves, our staff, and our teams. Have we reflected on how the constantly changing policies and regulations affected our families and our communities as a whole? There was a report out from Montauk and Kuhl published in 2020 that also noted that the psychological impact of COVID-19 related separation will reverberate for years and likely result in high numbers of people needing trauma-related services. So as you know, the lack of visitation, the inability to know what was happening behind our closed doors, and of course, all of the media reported cases of actual poor care has led to increased anxiety, fear, and distrust for a lot of our families. I personally fell into this as well. In a way, I kind of believe it to be human nature. I mean, this was a person that I love, a person that is extremely dear to me, but when I laid my head down at night to sleep, I wasn't sure that they were safe, physically or emotionally. So back in October of 2020, I was actively working a COVID outbreak in a home here in Kansas. I was personally witnessing the devastation firsthand. I was actively restricting families from coming to see their loved ones at the same time I was fighting to see my loved one. My mother-in-law lived in a care home that I have dedicated half of my adult life to. I mean, these were my friends, people that I respect and people that I truly love, but yet I was not comfortable. I was uneasy, I was anxious, I was untrusting. Ultimately, I was scared and I let my fear overpower my thoughts. Okay. A few weeks ago, we highlighted the QI process in the PDSA cycle, Plan, Do, Study, Act. As we move through today, I want you to consider us being in that study phase. What can we learn from the past 2 years that can help us to achieve success today and start to repair the damages of yesterday? There's been extensive research out that shows the various benefits of reflection within quality improvement and a dynamic link among reflection, learning, and change. We are going to make it out of this pandemic strong and healthy. We must focus on rebuilding trust with our families and rebuilding trust within our communities. And to do that, we must reflect and consider the point of view of everyone involved. We have to understand their thought process and their pain to know how to overcome this challenge. In the next few slides, Mitzi's going to share with us actual concerns voiced by family members across our 4-state region. Again, by understanding the point of view of our families and acknowledging that, yes, poor outcomes did occur, maybe not within your home, but it may have happened within your town or the town next door, okay, or to another family member that lives in another state. But because of that, all compiling, it drove fear. So again, we can only work to rebuild the cohesiveness of our communities to ensure quality if we look at everybody's point of view. So with that, thank you again for joining us, and I will pass to Mitzi.
Next slide, please. Hi, I'm so glad to be with you today. And as Allison said, my name is Mitzi McFatrich, and I work with the Consumer Advocacy Organization. I've been the director there for going on 14 years. And in preparation for the conversation that we're having today, I reached out to our counterparts in consumer advocacy organizations in Virginia and South Carolina and Missouri, as well as those in Kansas. And I was able to gain from that a lot of understanding about what happened for families and what happened for residents during the pandemic that relates to this issue of rebuilding trust, of broken trust, of the kinds of difficult situations that families and older adults found themselves in. So one of the things that I know that we're all feeling is like we'd like to move on from COVID. The last thing we want to do is be focusing more on this really devastating pandemic that has impacted all of us, as Brenda said, both personally and professionally. But the truth is we can't move forward without looking back. And reflection will give us the context for where we are right now and understand from residents and families how they got to the place that they are during the pandemic. And the examples that follow, I just want to be very clear with you, are not shared out of judgment or any place that is harsh or critical. It really is only to illuminate what residents and families found to be incredibly difficult and challenging during the COVID pandemic and during the visitation lockdown. I can't encourage you enough to start by gathering the experiences and concerns of the people who live in the facility where you are and those of their families. And that's exactly what I did for this presentation today. Next slide, please. We know that COVID-19 had a number of negative impacts on older adults who live in nursing facilities. There was actual harm, there was abuse, there was neglect, whether intentional or unintentional. There were many, many older adults experiencing physical and cognitive and emotional difficulties because of the disconnection and isolation that they were having during the lockdown. Many of them and their families have used the word feeling imprisoned when they've talked to us about that experience, which is a pretty dramatic way to communicate about what that felt like to them. They had unrelieved boredom and loneliness, depression, anxiety, fear, and tremendous grief. Grief of loss of family, grief of loss of other resident friends, grief of loss of a way of life, all kinds of things, and an overwhelming sense of powerlessness, of having no ability to impact what was happening to themselves and in the environment in which they were living. And as a result, we saw a lot of decline in health and function, physical, cognitive, and emotional. Next slide, please. So I want to just talk about 4 different things that families talked about with us. There were more things than that, but I'm just going to focus on 4. And we're going to start with communication. So Estelle was a resident in a facility, and she was having an acute healthcare event. She was concerned because she couldn't see her family. She didn't have a way to call her family. And so she asked the facility staff to contact her family and let them know what was happening. The facility assured Estelle that they had done that, but when she finally was able to talk to her family, they reported having no missed phone calls and not ever having heard from the facility about this event. Another resident, Mary, talked about not being able to talk with her family. And it wasn't only Mary who experienced this, it happened for many, many people, that their families would call the facility, the phones would ring endlessly, and no one would answer. The other concern was that residents couldn't get facility staff to bring phones to them so that they could make calls out. And even though some care facilities received CMP monies or state funding for tablets to facilitate video communication, it didn't occur. And sometimes there was no communication for days and sometimes not for weeks. That was obviously very disturbing and worry-provoking for families and for residents. There was a resident who reported that there was a resident's family who reported that she had dementia and they were not able to do in-person visits. And the woman was not able to use a typical video chat device correctly because of her dementia. So the family provided an Alexa, asked for it to be installed. It was installed so that they could communicate with the resident without the resident having to do anything with the equipment. But after a couple of video chats, the facility decided that Alexa was video surveillance, and they refused to allow it to stay in place. There wasn't really any explanation for that, and there wasn't really any recourse for the family once the facility had made that decision and removed the device, and they went weeks without being able to see or talk with their loved one. Next slide, please. Visitation was the hard one, I think, for everybody. Compassionate care visits were supposed to be allowed from the beginning. There was a lot of confusion about what constituted compassionate care. Mark reached out to us because his mother, who was nearly blind and deaf, was also on hospice and at the end of her life. He had requested a visit. He received a visit. And then he was told he could not have additional visits. It wasn't unusual to hear that concern all across the states that we reached out to and spoke with. And then once visitation was allowed in the summer, when outdoor visits might have been possible and less of a danger, they were very slow to begin. And in some places, they didn't ever begin at all before lockdown sort of happened again as resurgence of new variants came along. And then there was not much speed when the ban was fully lifted in getting people back into the facility to visit with loved ones. Some facilities, even now, this month in March, we are hearing from families, some facilities continue to inhibit visitation. And that feels like bad faith on the facility's part to the resident and to the family. Next slide, please. So we all know that understaffing is a challenge and that it was widespread prior to the pandemic, But it was very severe during the pandemic. And sometimes that was because staff was out sick. Sometimes it was because staff decided to leave. Sometimes it was because people weren't quarantined well. And one of the things that families and residents reported was that the basic care that they were accustomed to receiving had been rationed. Showers were reported to occur weeks apart, and it wasn't uncommon for us to hear that it was 6 weeks between showers or baths for residents. We saw that there was rapid weight loss and lack of socialization, lack of cueing. Fingernails and toenails were overgrown. And families were, in fact, shocked by the changes that they saw in their loved ones when they were able to finally see them again. That felt particularly difficult for families and residents when they are looking at the thousands of dollars that they pay each month for care and then feel like that there is not adequate care provided, understanding that we were in the midst of a pandemic. Another woman, Sarah, talked to us about her mom not getting a shower for over a month or having her nails trimmed. And the assisted living facility where she lives said that her mom was refusing showers. Finally, on a weekend, Sarah took her mom to a salon, and the hairstylist said that there was so much buildup on her scalp that it took 7 washes to get it all out. The stylist said that was from months, not weeks of neglect. Next slide, please. And finally, something that is always hard for residents and families to deal with is the fear of retaliation. Any of us that are in a vulnerable position and who don't have control over our environment and our lives are accustomed to feeling less powerful, less in control. And sometimes we fear that there will be retaliation, withdrawal of compassion, withdrawal of opportunity to engage with others, if not outright loss of where we would be living. So I mentioned Mark a little earlier, who had asked for a compassionate care visit with his mom. He was able to get one visit with her. And then when he asked for another, he was, and these are his words, threatened by the administrator and told that he and his wife would have to take her home if they requested another compassionate care visit. He called us literally in tears, fearful that his mother's life was going to be further disrupted in the facility where she was living, and asked what he could do. We suggested that he report it to the state survey agency and also to reach out to the long-term care ombudsman and to let the administrator know that he was fully aware of what the CMS guidance was on compassionate care, and actually equipped him with the CMS guidance to be able to share. When he went back to the administrator and talked with her about those things, the woman did apologize, and she did back away from saying that his mother would have to leave the care facility. But as you can imagine, he was a little gun shy about asking for things after that, and so was his mother. So that fear of retaliation was a very difficult thing for them to deal with. Trudy's family would visit her at the window at the facility where she lived. And oftentimes when they would show up, they would find that she was in various states of undress, that there was neglect in the sense that her clothes were dirty. Sometimes she would be lying on the floor. When they called the facility with a cell phone, they were outside the window and they could see what was going on and asked to speak to the resident. The facility said that she was in the shower or she was sleeping, or offered other reasons why that Trudy couldn't come to the phone, even though the family could see that plainly wasn't the case. When the family pointed this out, then their window visits were banned and the curtains were pulled. And so they weren't able to see Trudy and they weren't able to see what was going on. And oftentimes we're told by the facility that Trudy did not want to see them, even though they had no reason to believe that that was the case. Next slide, please. So I know that those things were just as hard for you to hear as they were for us to hear. I'm sure that you have experiences during the time of COVID that didn't go well in your facility. Again, we're not talking about judgment. We're not talking about criticism. We're talking about how do we recognize what happened and how do we move forward. And one of the things I really want to encourage is, what are the ways that we can build resilience? How can we enable the capacity to recover from these difficulties as opposed to just toughing them out? And I think the best way to do that is by starting to talk with residents and families about what helped and what hurt from their perspective and from your perspective during the pandemic. So thank you so much.
We can move to the next slide. Thank you, Mitzi, for your time and for sharing that information. Mitzi will still be on the call with us as well for if anybody has questions. At this point is our first polling questions. And I'd like to know, do you have an active family council? So I know we have resident councils, but do you have an active family council? Okay, well, the results are pretty strong there with a no. So that makes the next part of what we're going to move into, I think, quite important for all of us. We can move on to the next slide, please. Take that box. Okay, so with resident and family engagement, this is a phrase that I'm sure all of you guys are used to. The culture change movement has been around for a really long time and really pushed for that concept of resident and family engagement. I truly think that we've made great improvements over the years, but unfortunately, COVID has changed the way we work, and therefore it's kind of changed our normal, the way we relate to one another, and in a way it's stalled, if not taken us aback just a little bit. So we can move to the next slide, please. This slide kind of goes over the why. So what are the benefits of resident and family engagement? I mean, truly, it gives the residents the personal autonomy and the ability to direct care. It's on purpose. It allows for better partnerships with the residents, their families, and the team as a whole. And again, if we're working cohesively, then we can ensure that the person we are serving is truly being served in a way that is meaningful to them and purposeful. Okay. Ultimately, by providing that person-directed approach into everything that we do, giving staff the tools that they need, giving our residents and our families the tools and resources they need, we are improving the life for all that we serve. We can go to the next slide, please. As true quality improvements, looking at things as measurable outcomes. So the last slide talked about the whys and the benefits for our residents, our staff, and our families, but organizationally, there's measurable outcomes. We can measure clinical outcomes. We can measure our resident and staff satisfaction scores. We can also have family satisfaction scores as well. And ultimately, we will see a decrease in the resident and family reported grievances and resident and family reported complaints to your state board. We can move to the next slide, please. So now we're quickly going to talk about how. So I kind of talked about, what is engagement? Why is it important? But now we're going to talk about the how. Okay. So with patient and family-centered care, it truly redefines the relationships by placing that emphasis on collaborating with people of all ages at all levels of care in all healthcare settings. It helps us to redefine what a family means and then determine how they will participate in our care and decision-making. The ultimate goal is to promote the health and well-being of those that we serve and allow that individual and their families to maintain some control as they're going through the healthcare continuum. This perspective is based on the recognition that residents, actually patients and families, are essential allies for quality and safety. Patient and family-centered care leads to better health outcomes, as mentioned on the previous slide, improved patient and family experience, better clinician and staff satisfaction, and ultimately a wiser allocation of resources, which is another thing that we need to think about in this post-COVID world. The core concepts of patient and family-centered care are dignity and respect, where we're listening to and honoring our patients' and families' perspective and choices, that their knowledge, their values, their beliefs, and their cultural backgrounds are incorporated into the planning and delivery of care, that we're sharing information. And this is an important one because a lot of the concerns that families are voicing is communication. They just want to know what is going on with their loved one. So we need to communicate and share complete and unbiased information with our residents and our families in a way that is affirming to them and makes sense to them. Participation, making sure that our residents and families are encouraged and supported in participating in our decision making. And then overall collaboration. And that is where my request for you today, where we can all come together, our residents, our families, our practitioners, our leaders, and we can collaborate in policy and program development, implementation, and evaluation, so that again, we can improve the delivery of care. So the International Patient and Families Centered Care, in collaboration with New York State Health Foundation and the Catholic Health Alliance of Canada and the Center for Clinical Ethics, developed a toolkit titled The Family Presence During a Pandemic, Guidance for Decision Making. Within this document, there are tools that were developed to help facilitate the decision making moving forward. That's why I said we're kind of in that study phase today. So these tools are intended to be used in tandem and by a collaborative decision-making team. In the next 10 slides, I'm going to quickly go over those 10 steps. Because each and every home and community is different, there's not, these questions are set to be like a self-assessment, probing questions. So I want you guys to just think about your own processes as we're moving through these next set of slides. You can move to the next slide, please. One of the keys on this slide that I want to push out is, are the right people involved in the decision-making process? Do we have the right people at the table? One of the things that I tend to see is that we bring in those that are always the folks that always have our back. But what we truly need to make sure that we're doing is bringing in those folks that are not our biggest fans. Again, we are reflecting on the past to help improve the future. So we need to include those people whose relationships with our teams were fractured by this pandemic. We have to include the voice of those who keep us on our toes. So as we're building our team, make sure that the representation on the team covers the diversity of the entire community you're serving. We can move to the next slide, please. Identifying key issues. So two of the key issues that Mitzi talked to us about were visitation and communication. Those are things that we can assess our current process and learn and see how can we do it better. Did you have open visitation before? Were folks able to come and move freely around the campus? What was your process for communicating with families before? A lot of times that communication happened in real time because they were coming into our buildings, they were coming to say hello, they were feeling the culture, they were talking with staff, they were visiting with their loved one. When that changed and we restricted visitors, did we ensure we had a process to communicate that met everyone's needs? Okay. So this is again where you need to identify key issues, as Mitzi mentioned, that was what did not go so well. What type of concerns are your families voicing? And how can we look at that, look at our processes, bring in their voice, and work together to come up with a process that does meet everyone's needs? We can move to the next slide, please. Reviewing the evidence. I'm curious and would like to pose a question to the participants on the call today. But have any of you reached out to a peer home to discuss common challenges and approaches? We are all in this together. Every nursing home across the nation, every care setting across the nation felt the impact of COVID. So have we reached out to see how are they handling visitation? How are they handling communication? How are they handling admissions? How are they handling their clinics? To see what are they doing that maybe we can take some lessons, apply it to our community, and have some success. Okay, I'm encouraging you to look outside of just the lessons you've learned within your own quality improvement journey. We can move to the next slide. But once we've identified our key area that we want to focus on and we start digging into it, when we're looking at our policies and our procedures and our processes, are we ensuring that those concepts of patient and family-centered care are there? How can we work to balance public health as well as patient safety, quality of life, and other concerns such as emotional and mental health needs? That's probably been one of the biggest challenges that we've all faced over the past couple of years. So again, looking at your process, making sure are those concepts and principles in place, and if what the families are asking for, if it's in conflict, again, how can we intervene? We can go to the next slide. Once making a change, say it's visitation, we are making a change, who is that going to impact? If it's impacting families who come in each and every day, they're going to have an emotional burden to that. So how are we going to overcome that? Families who may have come in every once in a while or work during the day and came in for late visits. That's another thing that we've heard a lot, is that visitations were set to 8 to 5, which we understand. We have regulations and you guys have things that you have to ensure are in place. Staff being one of them, somebody to screen them in. So if we restrict our visitation to business hours, what happens to those families who can't break away during the business day to come and see their loved one? Okay. So we have to identify what we're potentially going to be doing in a policy change. How will it affect our residents, our care partners, our staff, and the ultimate community as a whole? We can move to the next slide. When discussing balance, the benefits versus harm, within this toolkit, there are actual tools to help you with this. What they're looking at is what is the long-term benefit of if we implement this visitation policy of Monday through Friday, 8 to 5. What is the long-term benefit of this? What is the short-term benefit, the long-term harms, and our short-term harms? But then we have to break those down into, for the resident, the staff, the community, and the organization as a whole. And again, within this toolkit, there are excellent resources and tools to help you break that down and balance out your benefits and your harm. Again, we need to, how do we balance it for all key groups impacted? If we're really going to make this movement, we have to make sure we're considering everyone as we're moving forward and how it impacts everyone. We can move to the next slide. At this time, then we're making our decisions. So we've went through, we've studied it, we've reviewed our policy, we've reviewed the evidence and best practices that's going on. So now we've decided to go ahead and make that change and put it into policy and practice. Now we need to decide, have we clearly outlined the changes? Is this new process reliable? And what is our QI process to ensure reliability? But then how are we communicating this process to all parties involved? Is there an appeals process? Is there a way that you take feedback so that you can ensure that what you're recommending, what you've just changed, is actually appropriate in meeting the needs of all people? We can go to the next slide. Again, communicating. We need to make sure that we have a great process for ensuring that decision-making is transparent and being communicated. A lot of times, again, when we look back at even back to my own experience, I trusted these people wholeheartedly, but the fact that I couldn't communicate in real time at all times brought anxiety. So again, who are the best people or groups to communicate? If we build up our staff as well and we share key messages with our staff, it can help to be those, to be messengers as well. We can move to the next slide. And this takes us into your implementing changes. So this is your act phase. So we've studied, we've reviewed evidence, we've put our plan into place, we've educated on that plan and policy changes, we've communicated, and now we need to implement those changes. We can go to the next slide. And then ultimately, in in pure QI fashion and PDSA and reassess the context, relevance, and outcomes. What went well? What did not go as well? What feedback did we receive? And then taking all of that together, do we need to make more changes? Is it working? Is what we're doing today still pertinent to today? We can move to the next slide. So our second polling question of the day before I pass to Mike to share his best practice is, do you involve residents and families in your quality improvement efforts? Very nice. We are leaning on the yes side, so that is awesome. We appreciate you guys answering these questions. Okay, so it looks very good. About 75% are yes. So thank you for that. If you have anything that you would like to share in chat, maybe any examples of how you use your residents and family members, feel free to share those. At this time, we can move to the next slide. And I would like to introduce Mike. Again, I am excited to bring Mike today. Mike is with Mount St. Mary, located in Wichita, Kansas. They are a CMS 5-star rated community. They have had 2 consecutive years of zero deficiency surveys. So yay, great job, Mike and team. I also wanted to point out, because we are talking about the relationships with our residents, they've also had no complaint related surveys or citations for the past 3 years, which really just goes to show that their relationships with their community is grounded in trust. They have a resident vaccination rate of primary and boosters at 100%, and they also have greater than a 90% staff vaccination rate. So at this time, I am going to pass to Mike and let Mike talk about how they engage their residents and community members for successful vaccine clinics.
Good afternoon. Can everybody hear me okay?
Yes.
Okay, good deal. You know, from the outset with the pandemic, it was very hard to deal with the changes that were just being thrown at us right and left. And when it came to visitation and family involvement, what worked one day, we found could change in an hour, could change on a dime, could change in a minute. So things were constantly changing. But from the outset, our overall goal, even with the pandemic, was for us to look for ways that we could keep our residents and family members involved with us. So when it came to like visitation, instead of saying, no, you can't do this, no, you can't do this, we looked for ways that we could still keep the residents and family connected in whatever way we could do that safely. Many of, as the pandemic progressed over the first year, many of our family members became strong volunteers here. It was a way for them to be able to participate in the building and be part of the process. And we would treat our volunteers just as if they were employees, only difference is they don't get paid for their work, they're volunteering. So, but that was a bridge that allowed many of our family members to stay involved with our residents, and it allowed many of our residents to do volunteer activities as well in the building. So can we go to the next slide, please? One thing that I was asked to focus on was our vaccine clinics that we did here. We were all I can still remember that day when it was January 2nd of 2021, when we could get our residents vaccinated here and our staff vaccinated here and our volunteers vaccinated here. And that was important to everyone, because everybody at the time felt like, okay, if you get vaccinated, maybe this pandemic thing would just go away and things would be able to get back to where we wouldn't have to worry about how we're visiting to keep our residents safe. So we wanted to very much involve our residents and involve our volunteers, our family members, as much as we could in the vaccination clinic, because it actually was a a focal event that would allow us to have people participate with each other successfully. And when you look at this sheet, you see there's a lot of things that go into doing a vaccination clinic. In the early days when they were being done, and ours were being done through CVS at the time, it was complicated. There was a lot of things that had to be done. So you just looked at the very many activities that had to be done and looked at ways you could involve your volunteers in things. And when you look at this bullet list here, you can see down, create, distribute information on time. We had residents that helped create posters announcing the clinic and information on the clinic. We had different people involved in distributing it out to the residents' families and staff. And then we made a variety of volunteer assignments for the day of the clinic and provided training. Keep in mind on all of this, anybody who wanted to be a volunteer here went through some core infection control training for the principles of good COVID prevention and infection control. Of course, the 6-foot distancing, the wearing of the mask, the frequent hand washing, and are you washing your hands properly, and so on and so forth. So there was an investment among the individuals to do things that would help keep all the residents safe too. So next slide, please. The day of the clinic, the volunteers fulfilled many, many different assignments, and I just listed a few of these here. You know, we on our first clinic, we had over 150 vaccines given within a 2-hour period. It was very, very rapid and very quick, and you got to be very organized for that. So different people that were volunteering helped with greeting the participants and showing them where to go, getting them through the screening process, because everybody had to be screened before that came into this building, even before they could go to the clinic, to make sure they weren't actively showing any COVID systems, and then getting them there. And then we had various waiting areas, and we had different people assigned to various waiting areas. Those are all things that a lot of the residents just looked forward to being productive, to have something to do to help with the clinic. So we provided refreshments in the aftercare area where they had to wait for 15 minutes and had volunteers there letting them know when their 15 minutes were up and help and making sure they exited the building safely. You know, there was various activities to do with restocking bottled water, refreshments, making sure our vaccination staff that were doing the vaccinations were being taken care of too. Of course, lots of copies needed to be made so that we wouldn't lose track of who got vaccinated and was this their first dose or second dose and so on. And that CVS had all the documentation they needed, and we had all the documentation needed too. So just a variety of things. After the clinic was over, there's also a lot of work to clean up and disinfect and kind of get things back to where they belong. So I guess the important thing here is to look for ways in doing some of your activities that you can involve your residents, that you can involve your family members in, because if they feel like they're part of the process instead of outside the process, I think your relationships that you build there really become important. So I don't know if anybody has any questions that I can answer for me. Other than that, that's what I wanted to share with you.
Thank you, Mike, and thanks for everything that you guys continue to do. This time we can move to the next slide. I just wanted to leave you guys with this slide here. This is also from the Institute for Patient and Family Centered Care. It's called a Better Together Toolkit. What you're seeing on your slide is the pocket guide for staff. There is also a pocket guide that you can give to your families. So as you're looking at your program and maybe need some resources, please go to the IPFCC website and look at the Better Together pocket guide. Again, I want to thank everyone for joining today. I am going to pass to Allison here in just a minute or a second to close us out. But before I do that, I just wanted to, I hope that you all got something out of today, some ideas on how you can incorporate family voice into your QI, because we cannot do this alone. I also wanted to close my part with a quote, my favorite quote, which is Maya Angelou: do the best you can until you know better. And when you know better, do better. At this time, I pass to Allison to officially close us out.
Thank you, Brenda, and thank you, Mitzi and Michael. We really appreciate your time, and it was a wonderful presentation. So while I go through the last few slides to close this out, I just want to give everybody the opportunity to ask any questions. So, or share. If you do have a question, please type your question in Q&A, or if you'd like to be unmuted, please raise your hand. And it looks like someone has raised their hand. Mary, are you able to unmute?
Yes, and I see a question from Terry Turner that says, with including the families, the challenge has been with our short stay patients. We have a jumpstart meeting on admission. This meeting occurs the next business day of the admission. The long-term care population families are more engaged with facility activities and any concerns in a very productive way. Our short stay admissions are more challenging. How are many of you managing the behaviors of these families and patients? Many staff state they don't want to do this anymore because of how they are treated by the families. But we are encouraging families to visit, be involved in the initial jump start, meeting all the department heads the next day. Trying to balance this is a challenge. How are others dealing with this?
Okay, very good. And so everyone, please weigh in and share how you guys are addressing your short stay residents. And was there someone who wanted to be unmuted?
This is Laura. I had just raised my hand because I'd seen some things in the chat that I was hoping people were able to see, which Mary just read some of that. So yeah, I'd also like to know if anybody else had any problems managing the vaccination cards. Was that an issue for anyone else other than me?
All right, so while we're waiting for people to type in chat or raise their hand, I'm going to go ahead and move through some more slides. So this is our weekly newsletter. It's the weekly dose. Hopefully everyone is getting it and finds it helpful. If you haven't received it, please check your junk or your spam folder because it may have accidentally found its way there. And if you aren't receiving it and would like to be added to our mailing list, please reach out to us and we will get you added. And then here are several of our HQuinn resources. When you get the slide deck, you can access all these resources by the links. We also have these resources located on our resource center. And all you have to do is go to hquinn.org to access the resource center, and you can search for resources by topic and setting. And then here's some additional non-HQuinn resources that we thought might be helpful to you. And then our next week's session is titled Highlighting Best Practices. This is the St. Louis Roundtable. Dr. Charles Crecelius, he is our guest speaker next week, and he'll discuss their structure that provided coordination across the health systems and nursing homes during the pandemic. So same time next week. And thank you again for joining us today. And if you do have follow-up questions, that that you think of after today's session, or if you would like assistance, please reach out to your HQuinn state representative. Their names and contact information are here on the slide. And then also, please remember to complete the evaluation. That really does help us in developing our future events. And before I close out, I just want to do one last check for any Q&A or anybody that's raised their hand.
This is Brenda. On the question that was read regarding the short stay, again, I would encourage maybe looking at your admissions process, the person who goes out and maybe screens those at point of contact with the hospital, having a sit-down conversation and making sure when they're screening those new admissions that that's your policy, your procedures are very well stated up front. And that way the families have an option to maybe choose somewhere else if they're looking for some other type of service. Otherwise, pull in your staff and try to see and quiz them on the types of issues that families were complaining and see if there's a trend to that. And maybe you can identify an approach based off of the trends and the largest concerns being voiced. And I also I saw a great example, and I don't know if everybody else saw it. It was about communication. And it talks about how this team did a phone chain and each department head had a certain number of patients that they had to make a minimum of 2 calls per week. So then they talked about how they did that. But as a follow-up from a quality improvement perspective, they noticed that the administrator then also made random calls each week to the family just to ensure that the family was satisfied with the communication and give the family an opportunity to then talk to that administrator. So I just thought that was a great example. And so that is in the chat. So thank you, Terry, for sharing.
Okay, last call for questions. All right, well, if there are no questions or anyone has raised their hand, we're going to go ahead and end today's session. Thank you all again for joining us. We appreciate your time. I hope everyone has a wonderful rest of the day.
Thank you.